Is it okay, Dr. Ramesh?
Yes, sir. We are live.
Okay. I'm very happy to have Dr. Akriti Sharma with us today.
Thank you, sir.
I met Akriti in the Shatabdi Express from Delhi to Chandigarh, and we were sitting next to each other. And just before getting down in Chandigarh, I started talking to her. And she told me that she's a eye specialist. She's MS Eye Ophthalmology. So I requested her to share her experiences with us, and she agreed. I was very happy. And today we'll come to know so many things about eye infections and also allergies of the eye. It is going to be a very great session. So all of you will learn so many things. So over to Bhupinder, please. Bhupinder?
Hello. Hello.
Yes.
Hello.
Okay.
Sir,
Please go
am
ahead.
I audible?
Yes, you are.
Thank you, sir. Thank you. Good evening, everyone. Hope you all are doing well. I, Bhupinder Sharma, welcome you all here in this today's talk. Before we kickstart today's discussion, I would like to introduce some of eminent personalities. First of all, I would like to introduce Dr. Arvind Deshmukh, President of Microbiologist Society, India. Sir is very kind and very sportive, always promote us to do our best. Secondly, it's a great pleasure to introduce Dr. Savanjit Singh, State President, MBSI, Chandigarh Tri-City. Dr. Savanjit has many achievements to his name. Sir is listed in top 2% global scientist for 3 consecutive years. He served in MTCC and Gene Bank, now the first IDA in India. He is also member in 2 WFCC committees. He is the member of Task Force National Biodiversity Authority, Chennai. He is also awarded with Loyola Environmental Award. He is also fellow National Environmental Sciences Award, Lifetime Achievement Award 2022. He received Lifetime Achievement Award 2022 by St. Xavier College, Ranchi, and his publications are in high impact factor journals, and the articles are highly cited in the literature and cited 17,000 times. And sir, along with Dr. Deshmukh is our panelist for today's discussion, and it's an honor for us. Thank you, sir, for being here with us. And finally, it's with a great pleasure, I would like to introduce our keynote speaker of today's event, none other than Dr. Akriti Sharma. Welcome, ma'am.
Thank you so much. Thank you, sir.
Dr. Sharma is MBBS, MS Ophthalmology. She done her MS, Master of Surgery, from DY Patil Medical College, Pune. Currently, she is serving at Seva Hi Seva Trust Hospital, Panchkula. And as I already told, ma'am is the keynote speaker in today's meet. And our topic of discussion is common ocular infections and allergies. So the event start with the presentation of Dr. Akriti, and it is followed by the discussion with our panelists, Dr. Savanjit Singh sir and Dr. Deshmukh sir. So without wasting much time, let us welcome Dr. Akriti Sharma, and thank you very much for listening me. Over to you, ma'am.
Thank you. Thank you. And I'm highly grateful to Dr. Swavanjeet sir for giving me this opportunity. I'll be starting with my presentation. Is the presentation visible to everyone?
Yes, it is.
Okay. Thank you, sir. Thank you. Okay, so today we'll be talking about ocular infections and allergies. Starting with the simpler infections. First, we'll be discussing bacterial conjunctivitis. So the most common isolates or the causative organisms of this particular disease are Streptococcus pneumoniae, Staphylococcus aureus, Haemophilus influenzae, and Moraxella catarrhalis. And a minority of cases are caused by Neisseria gonorrhoeae. And mostly the symptoms associated are, where there'll be pain, there'll be watering along with sticky discharge. It's less common seen in the OPD setup nowadays. Now, next coming to allergic conjunctivitis. Now, acute allergic conjunctivitis is a common condition and caused by an acute conjunctival reaction to an environment allergen, usually a pollen, or it can be dust allergy or allergy to any other substance, or like allergies like hair dyes or any chemicals. Next we come to viral conjunctivitis. So viral conjunctivitis is a common ocular infection. Basically, adenovirus is the most common cause. It usually occurs with associated symptoms like fever, cold, runny nose, etc. And usually the patient comes to the OPD with the complaint of, they tell me that they suddenly woke up and developed eye pain, watering and redness in the eye. It usually starts unilaterally and goes on to become bilateral. It is highly contagious. So, talking about allergic conjunctivitis in detail, we will discuss vernal keratoconjunctivitis. Now, vernal keratoconjunctivitis usually occurs in young boys in summer time, and it is a recurrent bilateral disorder, which is Ig cell-mediated immune mechanism. So this can be conjunctival or can also involve the limbus, and it usually appears as papillary hypertrophy. Now in this slide, you can see the papillae. The first picture shows micropapillae or the smaller papillae, and the second picture shows the bigger or the giant papillae. Now, the other form of keratoconjunctivitis can be atopic keratoconjunctivitis. It is a rare disorder, usually seen in adulthood, and asthma is very commonly associated with this. Now, coming on to the other set of infections, the more grave set of infections, we have the infectious keratitis, or commonly called as the corneal ulcers. Now, corneal ulcers, we'll first discuss about bacterial keratitis. It is one of the most important form of infectious keratitis, and the risk factors can include corneal trauma, eyelid disease, ocular surface disorder, compromised or compromised local or systemic immunity. Now, the principal groups of bacteria which are primarily responsible include the Streptococci, the Staphylococcus, the Pseudomonas, and the Enterobacteriaceae. Now, Staphylococcus species is the most common cause of bacterial keratitis as per the text in the journals, and the certain bacteria are there which can invade an intact cornea, which includes Neisseria, Corynebacterium, Haemophilus, Shigella, and Listeria. Now, the general symptoms the patient presents with are decreased visual acuity, there is a vision loss. Then there is photophobia, there is pain in the eye, redness, and discharge. The treatment usually constitutes combined fortified drops like 5% cefazolin sodium and 1.3% tobramycin sulfate given in hourly dosage for the initial 48 hours. But then it is tapered to 2 hourly dosing. Fluoroquinolones can also be given like ofloxacin, gatifloxacin or moxifloxacin in their respective doses as a monotherapy. And topical cycloplages like homide or atropine can also be given, which helps to alleviate pain and ciliary spasm. And other like surgical, if the ulcer is not confined by this medical treatment, then surgical therapy can also be done, which includes tissue adhesives like cyanoacrylate, patch grafting, and therapeutic keratoplasty. Coming on to one of the most common cause of blindness in India, which is fungal keratitis. Now it is common in the developing countries as compared to the developed countries. The risk factors involve trauma, contact lens usage, ocular drugs like topical anesthetics, corneal surgeries, and systemic diseases like diabetes or immunocompromised states like HIV/AIDS. Now, worldwide, Aspergillus species is the most common fungus responsible for fungal keratitis, whereas in northern United States, the Candida species and the Aspergillus species is the most common, and in southern US, Fusarium species is the most common. And in India, it has been reported that 44% of all corneal ulcers were found to be fungi. In this case, the symptoms include foreign body sensation, gradually increasing pain, and diminution of vision. In this type of an ulcer or infectious keratitis, the signs or the corneal signs are more than the symptoms. The signs include, as you can see in this picture, feathery margins. This is a dry-looking ulcer with satellite lesions. And there can be a fixed hypopyon associated with it. The treatment in this case majorly includes natamycin 5% suspension. Natamycin is basically a fungicidal and it binds to ergosterol present in the fungal cell wall. And that's how it initiates its fungicidal action. In addition to the antifungal drugs, a broad spectrum antibiotic such as fluoroquinolone can also be added to prevent secondary bacterial infection. Cycloplagic may be given 3 times a day to alleviate pain. And non-healing fungal corneal ulcers can be treated by intravitreal or intracorneal amphotericin B injection in the dosage of 5 to 7.5 milligram. And surgical treatment can be further done for resistant ulcers such as debridement and therapeutic keratoplasty. And a little more about fungal corneal ulcers is that we can use the following stains to rule out a fungal ulcer. First of all, we can, the primary mode is to take a scraping from the base of the ulcer with the help of a Kimura spatula or a 15-number blade. And it can be put in 10% of KOH to rule out fungus hyphae. And also calcofluor white stains can be used. And the best stain which can be used for fungi is modified Grocott Gomori methanamine silver nitrate stain. And the current modality of investigation is confocal microscopy to identify the hyphal elements of fungi. Coming on to keratitis. This is the most common keratitis in the developed world. Now, various viral infections can be broadly classified under this category, which can cause, the causes can be herpes simplex keratitis, varicella zoster, and adenoviral keratitis. See, adenovirus can also cause viral conjunctivitis, which can lead to further involvement of the cornea, leading to viral keratitis. Now, the keratitis can manifest as one of the following. It can involve the epithelium, it can involve the stroma, it can involve the endothelium. And the treatment is the antiviral agents which depends on the depth of the involvement of the cornea. In epithelial, broadly classifying, in epithelial keratitis, we do not prefer to use steroids, but in stromal keratitis, we might use steroids in certain cases. Now, surgical therapies which need to be performed in severe cases may be conjunctival flap, amniotic membrane transplantation, tarsorrhaphy, application of cyanoacrylate glue, and a lamellar or penetrating keratoplasty. Moving on to a grave pathology of the eye, which is the endophthalmitis, the most dreaded complication for any ophthalmologist or an ocular surgeon. Now, endophthalmitis means bacterial or viral infection inside the eye, which involves the vitreous and or the aqueous humor along with it. Now, most cases occur after ocular surgeries, more commonly cataract surgeries. Mostly it presents itself after 4 weeks of cataract surgery. That's where the ocular surgeon needs to be cautious. Till 4 weeks, the patient needs to be monitored for the same reason, due to the possibility of the same reason. It can occur as a result of trauma or as an extension of corneal infection or even as an extension of endocarditis. Bacillus cereus is the most common cause for a post-traumatic endophthalmitis, and Staphylococcus aureus and Streptococcus are most common organisms in case of endogenous endophthalmitis associated with endocarditis. Candida albicans, on the other hand, is the most common organism causing endogenous fungal endophthalmitis. Now, mostly the treatment is direct injection of antibiotics into the eye or intravitreal injections, which is mostly vancomycin, 1 milligram per 0.1 ml, plus ceftazidime or amikacin in the dosage of 0.4 milligram per 0.1 ml. And for this to perform, first a sample of vitreous humor is taken and gram staining and culture is done for the same to rule out the organism or the type of organism infected. And the second component of treatment is vitrectomy, which is basically the surgical debridement of vitreous to clear it of any infection. Now coming to orbital mucormycosis, these cases were reported very rare before COVID happened. It was mostly associated with immunocompromised states like diabetic mellitus or diabetic ketoacidosis, neutropenia, chronic steroid use, or any other hematological malignancies. But there was a sudden spike in these cases seen after COVID, which was a very grave condition for all the ophthalmologists and all the ENT specialists, and certain radical surgeries had to be done for such patients. So it is an aggressive opportunistic infection, which basically starts in the sinuses, and it progresses onto the orbital tract. So basically involving the rhino-orbital tract. It involves the sinus, and sinusitis symptoms occur like sneezing, headache, periorbital headache or retroorbital headache, which goes on to involve the orbital tract, which leads to symptoms like soft tissue swelling, eyelid erythema, conjunctival congestion, or there is increase in the size of the protrusion of the size of the eyeball, proptosis, extraocular movement restriction, cranial neuropathies, especially the third and the fifth nerve are most commonly involved, and loss of vision. And this can further involve the contralateral or the other eye also via the cavernous sinus, and leading to, if not controlled on time, it can go up to intracranial extension, and which can lead to symptoms like focal seizures, etc. And so basically the mainstay of treatment is antifungal, which is amphotericin B at a dose of 5 to 7.5 milligram per kg per day. There is another ocular intervention that can be performed in such patients and which has proven to be successful in those days, which was transcutaneous retrobulbar amphotericin B, also called as TRAM. So In this case, we give 3.5 mg per ml of amphotericin B directly is injected inside the orbit of the patient. Around most preferred number of doses are 5 to 6 number of doses, but you can also go up to 10 doses for a patient if the patient tends to respond to the treatment. Otherwise, the final treatment performed in these patients is enucleation or exenteration. Exenteration mainly because the fungus tends to erode or eat up the orbital bones along with it, along with the sinuses and the orbit. Thank you so much.
Thank you, Dr. Akriti.
It was a wonderful, excellent talk, Akriti. It was a very nice talk. We really
Thank you, sir.
aspects of infection and allergy.
Thank you, sir.
It was a very, very nice eye-opener, actually.
Thank you.
So, what are the major microbes which infect the eye? What are the microbes?
Sir, basically the major microbes can be Staphylococcus aureus, Streptococcus can be the major involvement, but in severe cases it can also be Neisseria gonorrhoeae or Haemophilus influenzae.
What about Mycobacterium?
The Mycobacterium can also occur, which can further lead to uveitis, sir.
Okay.
Yes, sir.
So, Mycobacterium, it's a very bad microbe. It also causes TB.
Yes, sir.
Causes TB also.
Yes, sir.
Okay, I was just wondering if the eye is bad, it is extracted out, right?
Yes,
It is taken out. In what conditions the eye is removed from the body?
yes, sir. Sir, it can be conditions like endophthalmitis, the one we talked about in this presentation, or it can involve all the coats of the eyeball and go up to the retina or the posterior segment also, which is panophthalmitis. The same can be the indication. It can be orbital mucormycosis, orbital aspergillosis, or a painful blind eye.
Right. In that case, the eye has to be taken out.
Yes, sir.
Yes. And I heard about one cow tail hitting the eye. Cow tail, gaye ki pooch, hitting the eye. So please tell us something more about that.
So basically, any sort of vegetative trauma, like any sort of farm, say, it can, enter, the particles can enter your eye, or you can talk about the cow's tail. It basically leads to fungal keratitis.
Yes.
The one we talked about in our presentation, and it will be more of a patient won't have a lot of symptoms, but will come with a lot of signs. And if not treated on time, we'll have to surgically debride the lesion, which is another complicated thing, and it doesn't get yield very good results, so it needs to be controlled at the initial stage itself.
It is very dangerous, this eye hitting the eye. Very, very dangerous. Okay, after COVID, COVID-19, I heard that even the yeast, fungi, mucor infection is there. What do you say about that mucor infection?
Yes, sir. So orbital mucormycosis and orbital aspergillosis cases started coming up after COVID-19. So basically, they involve the paranasal sinuses and were rarely seen before COVID. But then the paranasal sinuses, they further go on to involve the orbit, which leads to literally vision loss. And it can also lead to orbital cellulitis sort of situations, which can lead to further cavernous sinus thrombosis.
Right. Even this aspergillus and candida yeast, they infect the eye, right? Are they less dangerous or more dangerous than mucor?
Sir, actually, it's mostly seen that mucor has more of a tendency to involve the orbit. Aspergillosis is also dangerous, but it usually tends to restrict itself to paranasal sinuses. But orbit is more mucor is more dangerous as it has more. It is more prone to involve the orbital and the cavernous sinus and cause cavernous sinus thrombosis also. So it's more dangerous.
That means even aspergillus is very dangerous.
Yes, sir. Aspergillosis is also very dangerous, but mostly it doesn't have a lot of predilection to involve the orbit. It mostly restricts itself to paranasal sinuses.
Right. Now, you tell us a bit about allergy. What are the allergens nowadays? Common allergy.
So it can be pollens, it can
Yes.
be dust, it can be hair dyes, or any other, even as simple as a kajal, as a cheap quality kajal can also lead to that. And a certain change of cosmetics can also lead to allergic conjunctivitis, which
Of course,
has been observed in COPD.
they are all chemicals. That's why.
Yes, sir. Yes, sir.
Chemicals. Right.
Yes, sir.
Yeah, I'll tell you one very good case. One of my auntie went to Dr. Bhajan Singh. He's a very senior eye specialist.
Yes. Yes.
And she had redness in the eye, lot of redness.
Yes.
So she went to Bhajan Singh Saab 2-3 times. Then Dr. Saab told her, "Are you using hair dye?" She said, "Yes, I use hair dye." He said, "You stop the hair dye." And my auntie, she stopped the hair dye and all the redness vanished. There was no more allergy.
Basically, so the precipitating cause was removed, which
Yes.
is most helpful in allergic conjunctivitis.
Right, right. So what are the precautions we can take to avoid allergy?
Sir, basic precautions like wearing sunglasses while going out, especially the people who tend to ride two-wheelers or motorbikes, they should be using sunglasses more often. And sir, a basic recognition of the allergen and trying to stay away from it, maintaining basic cleanliness and not to travel into dusty areas, especially.
Right.
These can be the major things. Yes.
Yes. Some people, they stay near the cement factory.
Yes.
Cement is very small molecules of cement.
Yes.
So they have a lot of problems, not only eye, but also in the lungs.
Yes.
Yes, they can wear goggles and specs, but
Yes.
some parts will go to the eye also.
That's true, sir.
So they cannot avoid the allergy of cement.
Yes, sir. So
That is
the
also
best.
dust.
Yes, sir. So in this case, we prefer to tell the patient to relocate, but if the patient cannot relocate, then to stay indoors more often and not
Right.
go outdoors.
Right.
Yes.
It should be indoors.
Yes, sir.
Very nice. I mean, you have answered the queries so well. Huh?
Yes, sir.
Now, I request anybody, if anybody has got a question, you can ask her. Does anybody have a question?
Hello, sir. I have one question. It is not related to the topic, but I just wanted to shortly understand about cataract. Ma'am, could you please explain shortly?
Sure. See, basically, cataract is basically age-related, more often age-related, but it can occur in association with other systemic issues too. But what happens in this case is there is opacification of lens and the lens capsule. So it's mostly an age-related change, but the thing is that microfibrils present in the lens capsule and the lens can get so there is a distortion of the fibrils, they get separated, and as a result of which cataract or opacity results in the lens capsule. Am I clear, or should I explain it more?
Fine.
Okay. Sandesh, nowadays we have laser treatment for the cataract, right?
Yes.
You can go in and walk out of the hospital same day. I mean, you have the cataract operation, you walk out. But earlier, it was done by hand. They were stitching the eye. They were performing manually. The doctors were so talented, very talented doctors. And one of them was my Dr. Bhajan Singh. He performed so many cataract surgeries, so many with his hand. And fine thread was there, and he used to do with his hand. And he was very successful. The old people were very, very thorough, I should say. They used to perform so good surgeries manually.
That's
isn't it?
That's
You
yes, sir.
know, Akriti, they were really
Yes.
very great people.
Yes,
But
sir.
now we have modern techniques like laser and all that. So it is done very fast.
Yes, sir.
Do you agree with me, Sandesh?
Yes, sir. Yes.
Yeah. Nowadays, hardly anybody does by hand. They do by laser only.
Yes, sir. Sir, it's mostly the previous technique was extracapsular cataract extraction (ECCE), which
Yes.
involved the usage of sutures. And
Right.
then we moved on to small incision cataract surgery, and now we are doing robotic femtoLASIK surgeries, or we are doing phacoemulsification surgeries. So
Yes.
basically, our whole idea is to reduce the size of the incision and the port, sir.
Right. And nowadays, refraction is done also by machines, But
Yes, sir.
the old surgeons, old doctors, they used to, put hit on the wall,
Yes, sir.
some instrument, with some steel
Yes.
and some, and their
The
refraction was,
retinoscopy.
yeah,
Yes, sir.
that refraction was very, very perfect.
That's true. So
So,
even today, sir, I think the perfect form of refraction is retinoscopy as of now.
yes, that's very perfect.
Yes.
Any more questions? Anybody? If there is no question, Akriti, we thank you very much for the wonderful talk. We learned
Thank you,
so
sir.
much. And so many questions were asked and you answered them.
Thank you,
Now
sir.
over to Bhupinder.
Thank you, Akriti, ma'am. That's great. In detail, you
Thank you.
told everything to everyone. Any doubt? Anyone have any doubt?
Bhupinder, you can also ask some question if you like.
No, sir. Actually, जो discussion यहाँ पे हुई है regarding cataract और जो मेरी knowledge में था, one of my known undergoes femtoLASIK surgery and even after 2 hours वो comfortably देख सकते थे और उनका multifocal surgery हुआ था, multifocal lens डाला गया था.
Multifocal
And
lenses. Yes, sir.
हाँ, और that's better. So जो आज talk हुई है उसमें everything पूरा एक स्टेज में चला कि हर चीज हर एक उसको समझ आ रही है.
Very
So
good.
कोई क्वेश्चन मेरी साइड से तो नहीं है सर. And I would like to thank ma'am for her gracing important work and sharing with us findings and opinions. And I would also like to thank you, sir, for organizing this panel talk. Whole credit goes to you, sir, and sharing your experience with us. And along with you, Dr. Deshmukh also. He is our sportive backbone. He is our backbone. He sport in every aspect. So we thank you, you both, and as well as ma'am for today's talk. And I also extend a very hearty vote of thanks to the audience who are who is here being here with us. And that's all for today. Thank you and goodbye.
Thank you. Thank you,
Thank
everyone.
you.
Thank you.
Thank
Thank
you
you,
very much.
Sunil, sir.
Thank
Thank
you
you,
very
sir.
much. Thank you.
Thank you.
And I also thank Bhupinder for the nice conduct of this event. Thank you, Bhupinder.
Thank you, sir. Thank
Thank
you.
you. I'm very grateful to everyone. Thank you.
Bye.
Bye. बैठे बैठे सो रहे हैं.